Hi, Bo, Jean-Louis, everyone. Good afternoon. So first of all, my disclosure, I've done research and collaborated with a series of hemodynamic monitoring companies. I will talk about some concepts, not just around the Surviving Sepsis campaign, but I will take some points from that. But I will also start from definition of shock, and I will use some of the statements that we did together. There are some speakers here like Jean-Louis and Daniel, which was this consensus that we did with the European Society of Intensive Care Medicine a couple of years ago. So first of all, what is shock? Well, shock, that's how we define it, is a circulatory shock is a life-threatening generalized form of acute circulatory failure, but very importantly, it's associated with inadequate oxygen utilization by the cell. So there are two processes here. Here, we don't think we are bringing enough blood, enough oxygen to the cell, and at the same time, those cells, for these reasons, are not able to utilize the oxygen properly. Now, I'm often asked, is it more important low blood pressure or is it more important a high lactate? And indeed, if you look at the new definition of the Surviving Sepsis campaign and a new definition of sepsis, the role of lactate seems actually to be a bit lower than in the past. Actually, that is not true. Lactate is important, and a high lactate, a very high lactate, of course, gives us very important information. And indeed, if we put together, for instance, blood pressure and lactate in this way, we can see that actually there is a very synergic effect between the two. So for instance, I can look at patients with significantly good blood pressure, or we like to think so. Nevertheless, these patients, if they have a significant lactatemia, and so patients that have a lactate more than 2 or a lactate more than 4, despite having a systolic blood pressure of more than 90, well, those patients are associated already with a significant mortality. Those are high-risk patients already. Now, I can look at these things in the other way around. If I have a patient with a relatively low lactate, still having vasoplegia, so having significant hypotension, is associated again with increased mortality. And you can see that there is a synergy here, because the way I move up in this graph where I have significant vasoplegia and very high lactate, those are those very, very sick patients that do require significant interventions very early. But the important point is that even when I consider my blood pressure to be okay, still, if there is evidence of clinical hypoperfusion, and of course we're not just looking at lactate here, we will be looking at the patient, whether the mental state is okay, the respiratory rate, the skin, the temperature of the skin, the mottling, and so on. Well, if there is evidence of hypoperfusion, those patients are still patients that are sick, and they require some intervention, and that we may have to treat in our intensive care units. Now, what is the recommendation of the Surviving Sepsis campaign around some goals that we need to do in the initial resuscitation phase of septic shock patients? Well, the recommendation is around a MAP of 65 millimeters of mercury. I think as a safety threshold to start with, there is very little disagreement on this. I would say probably it's one of the most commonly used targets that we find. Nevertheless, the important thing is the mean arterial pressure should be individualized. And we're learning more and more about this, the fact that one size fits all. Probably it's okay when we have to start to do something in the emergency department, but very quickly after that, we need to start to think if the targets that I'm setting for my patient, are they really the good ones? Are they really the best one for the patient? Or maybe sometimes I have to do something slightly different. And so what was our recommendation in our consensus on shock around hypotension? Well, first of all, as I was saying, arterial hypotension, it is true that it's often very common in shock, but we can still have patients that are not hypotensive and they can still be considering shock because we defined and we recognize significant hypoperfusion there. And we recommended to individualize, that was indeed our very first statement, we need to individualize blood pressure target. Let's start with some safety. So let's start with a MAP of 65 in all patients. And if my patient is very vasoplegic, let's give fluids, but let's not delay giving some vasoconstrictors there. Let's start the noradrenaline early. Let's get the perfusion pressure up. Then we can start to think, oh, now maybe we can win the tough. I will skip this. Our consensus was not just on septic shock. We were talking also shock in general. But in septic shock patients, also we suggested that, for instance, if there is an history of hypertension and patients show a clinical improvement with a sort of a noradrenaline challenge, then those are patients in which we may consider going for a slightly higher arterial blood pressure. And the reasoning behind that was quite an important paper by the group of Asfar and Jean-Luc Bull, in which they looked at different targets of arterial blood pressure. And what they found was that while they couldn't find significant differences in mortality, when they looked at different outcomes, like for instance acute kidney injury, those patients that had an history of hypertension, they were less likely to develop acute kidney injury if they were running with a higher mean arterial pressure. Still, they were developing also a bit more arrhythmias, so there is always a risk and benefit in what we do, and that's why we didn't suggest that everyone with a history of hypertension should have a higher mean arterial pressure. Maybe we start low, but then if things don't get better, maybe we need to try to go a bit higher. Now, probably the biggest debate that we had in the last few years around the management of septic shock patients, as you know, is being around the SCVO2. And the SCVO2 was brought into light into the management of this patient by a seminal paper by Rivers, which I will not go and discuss in details, but was basically replicated in a series of randomized controlled trials. And a series of these randomized controlled trials showed no benefit for using SCVO2 as a target for the resuscitation of septic patients. Now, the Surviving Sepsis campaign basically said that if this approach, which was referred as early goal-directed therapy, was based on a protocol published by Rivers, and this recommendation described the use of a series of goals, and what they say basically that cannot be recommended now. Nevertheless, this protocol was not found to cause harm in the studies. So those studies were just finding that active management by clinicians at the bed space, measuring, interpreting, and applying the things at the bedside was probably equal that using this approach. But before we take it too simple and we just say to get rid of the SCVO2, I want to do a step back on the SCVO2. So first of all, these are the studies that didn't show any improvement in outcome. If you just look at these graphs, or if you just read the abstracts, well, they're all negative, right? So probably we should say there's nothing more that we can do about this. What's the point of measuring SCVO2? But let's go back to the physiology of SCVO2. SCVO2 is a complex variable. It's a number that comes actually from the interaction of many things that are happening in our patients and many things to which we can interact with our patients. And the linear relationship between the variables that we can change or the exponential relationship between the variables that we can change actually explains why the SCVO2 may be amenable maybe for treatments in some phases of the resuscitation of our patient, and maybe in some other phases it may become a bit more difficult to interpret. So for instance, in the early phases of septic shock, we know that the vasodilation creates a decrease in the vascular tone. While we are not really bleeding, we have a less efficient volemia. So we are relatively hypovolemic compared to the capacitance that we have. So our cardiac output is probably a bit lower in the early stage, and that's the paramount of giving fluids early in septic shock patient actually to try to restore the stress volume. And of course, the initial benefit that we get, for instance, for small increases in cardiac output, bring a much bigger increase in SCVO2 for low volumes of cardiac output compared then to higher values of cardiac output. Similarly, if I have a patient that is very, very anemic, the gain that I get from a value of 5 grams per deciliter going to 6 is much higher than when I go from 9 to 10. Okay, so these are things that we need to take in consideration when we treat our patients and when we interpret these variables. On the other hand, there is a much more linear relationship between oxygen arterial saturation. So therefore, there's no point of working so hard on getting the heart pumping very well if we don't get the saturation right. And at the same time, a very important way of doing hemodynamic therapy is sometimes working on the oxygen needs of our body. If I have a patient that is on septic shock due to a chest infection, that patient is really working hard. He's working hard with a high respiratory rate because he's compensating for a metabolic acidosis, with regards of where the infection is, whether it is in chest or somewhere else. On top of that, if I have a chest infection, I really have a patient that is working really, really hard there and may take into account of about 40% of the total oxygen demand in that case. Putting that patient to sleep, it is part of an hemodynamic stabilization. It is about removing the work of breathing and allowing basically the heart to deliver the oxygen where is more needed. So What did Rivers say? What did Rivers try? Well, Rivers was actually trying to see if in very sick patients, on top of basic hemodynamic assessment and management based on CVP, and we can question that, and based on mean arterial pressure, targeting an SCVO2 above 70% was bringing any benefits. And it did bring benefits in the trial. So why is it that the 3 randomized controlled trials that were done recently on a much larger group of patients didn't show any benefit? Well, we need to go back to physiology and to baseline. If I'm using a goal, and that goal is about driving to a certain direction, if I already achieve my destination at baseline, of course I will not be able to do anything meaningful with that guide. And indeed, if we look at the ARISE trial, the mean SCVO2 was 73% on average, so that was already above my target variable. The PROCESS trial, the mean SCVO2 was 71%, again, was already above the target variable, and PROMIS was 70%. What was Rivers? It was 49%. I would argue that if we were measuring troponins or cholesterols or any other variables here, probably would have made the same difference in these studies, because these patients were already resuscitated at the time they were enrolled in the studies. And actually, this is one of the probably of the biggest, I would say, successes that we need to praise Rivers and his group actually for this. It was some of the studies, like the study of Rivers, that made us aware of the fact that we need to intervene very early in this group of patients. We need to resuscitate them very early. And I think the progress in the recognition of these patients in the emergency department of giving fluids early has made the population changes over the year. It's not that the physiology is different. It's that the group of patients that we're treating now, when we go and assess them, are already resuscitated. So therefore, the SCVO2 simply may not be the variable to use to carry on with our resuscitation. But it doesn't mean that the low SCVO2 is something that we should neglect. The low SCVO2 is something where we should still focus our attention. On the other hand, the high SCVO2 does not mean that we have achieved our goals. And this is a study by the group of Jean-Louis and Daniel, in which, for instance, they showed that there are some patients in which the SCVO2 may be high and may still be responsive to fluid. So if I give a fluid challenge, the cardiac output will go up. Now the question whether that patient requires that cardiac output is different, and I will not be able to answer that just by looking at the SCVO2, but still it means that I may still have some reserve in that heart to increase cardiac output and oxygen delivery. And in this article, which I've asked Manu Rivers to write for Current Opinion on critical care, Rivers himself was saying, of course, there is plenty of limitation in the SCVO2, but nevertheless, when I have an SCVO2 which is low and there is still significant hypoperfusion, I can still have a green light to use SCVO2 to guide my treatment. And I think we should do that. And I think it's good practice if we have a patient with a central line, let's check a venous blood gas. Let's measure that. Let's interpret that information and let's apply that information in a way that is meaningful for that patient. And if the SCVO2 is low, it still can give us important information. So we will have a trajectory then. The lactate may be coming down, maybe still high, and the SCVO2 is still below 70%. We can still use the SCVO2 until the stage. But then at some point, maybe we will see that the SCVO2 start to normalize and the lactate start to normalize. Then we need to start to think about something more. And more importantly, the situation where the SCVO2 is high and the lactate is still high, well, then in that case, the SCVO2 is really not very useful to guide our therapy. What can we do in that case? I repeat myself many times on this, but I do believe that it's very important to go back to clinical examinations, first of all, and see if something has changed. If the temperature of the skin has changed, if the mottling of the skin has changed, if there is a kinetic in the way the lactate is changing. If it starts from 8 and it is now 5, yes, it's above 2, but it's a trend towards coming down. So all these things are things that we need to take in consideration. But if we want to see whether we can push maybe the cardiovascular reserve a bit more and see if we can still maybe give some fluids or give some inotrope to recruit some of the microcirculation, maybe some of the parameters that we can look at are, for instance, the carbon dioxide gap, which is looking at the difference in carbon dioxide between the venous blood and the arterial blood. And the rationale is that if we have districts in the microcirculation that are basically shunted, what happens is that the arterial blood will go there and not a lot of oxygen will be extracted. therefore the venous outflow will be rich in oxygen. On the other hand, I may have areas of the microcirculation that are not shunted. A lot of oxygen will be extracted. The mix of this venous outflow then will be recorded as a normal SCVO2, but actually what we know is that locally there is a lot of anaerobic metabolism going on in the part of the circulation that is shunted. If I have an anaerobic metabolism that is going on, there is a lot of production of energy in a less efficient way. So I have an increase in production of lactate, and at the same time I will have a bigger increase in the production of carbon dioxide. So a significant increase in carbon dioxide in the venous blood is something that I can look at if I compare to the carbon dioxide in the arterial blood to actually see if there is still room for potentially give maybe fluids or start an inotrope to recruit some of the microcirculation and to improve the perfusion of these patients. What were our recommendations around this? Well, we said that pragmatically, if there is a central line in place, that's a high-risk patient, well, let's look then at the venous blood gas of that patient, and if we have an arterial line, let's do couple blood gases and look at the SCVO2 and the carbon dioxide gap. We are not saying that the SCVO2 is what we should be using to guide the treatment in this patient, but it should be a stop check. And if the SCVO2 is low, the physiology is still there for us to do something about it. And then when that is normalized, if we think that the patient has not improved enough, maybe we can look at the carbon dioxide gap. So what are the things that we can do then to improve cardiac output when we decided how much we want to improve and if we've not achieved our goals? Well, of course, fluids are a cornerstone in the management of septic shock patients. I'm not going to go too much into the debate about whether the 30 milliliters per kilogram are too much or too little. I would argue that when you come to the emergency department, probably receiving fluids fast when somebody has made a diagnosis of shock is probably more important, and the risk-benefit is more important that we get the fluids quickly together with antibiotics, and actually then we can start to think later about the optimization of our therapy and see whether we can want to give a bit more fluids or not. When we are in the stage where we want to assess whether those patients, our patient will need extra fluids, our recommendation was that yes, when we see a patient, we always need to think that fluids are drugs, and therefore we always need to assess the volume status of our patient. That's just best practice. We've recommended to use dynamic over static variables to predict fluid responsiveness. It means simply that those absolute values of CVP that were considered to be good values in the past are not something that we advocate anymore. This actually is something that has been taken away also from the Surviving Sepsis campaign. And we also suggest that when we decide to give fluids, let's not just open the tap and give a liter. Let's do it in a methodical way so that we can assess the response to what we are doing. We are doing therapy, but we're also doing a test, so we're doing a fluid challenge that can inform us about further fluids that we want to give to these patients. There are a lot of devices that also we can employ now. When our patients do not improve quickly, I think it's important to go and have a look. I do believe we need to become all more and more familiar with echocardiography, at least for a fast, quick assessment of what's going on there. We know that many of these patients will have a certain degree of cardiac dysfunction, so I think it's really important that we have a look there and we start to make some diagnosis. If you have the possibility, you can even guide your treatment completely with echocardiography. However, nothing stops us to use echocardiography and still complement our management, maybe with some continuous cardiac output monitor. I do think that when we look at changes, when we give fluids, if we give a fluid challenge, this is something that usually we give in a few minutes. If we look at pulse pressure variation, if we do passively grazing test, the changes that occur are very transient and very fast. So we need to have tools that are able to have a continuous fast data acquisitions, and I will not go into the details of which tools you can look at. The recommendation that we had around monitoring for us was that we do not think that every single patient with septic shock needs a cardiac output monitor. But those patients that do not improve quickly with our therapy probably should actually have some assessment of the cardiac function. And quickly, we didn't define that, but in my practice, I would say if in a couple of hours, in 1 hour, 2 hours maximum, I don't see a significant improvement in that patient, I do want to go to the next level of monitoring to get some extra information. Now, the Surviving Sepsis campaign is a dynamic guideline. If you look at the different version, it has changed significantly over the years. There are people that criticize this approach and people that are a bit more fanatic about this approach. I actually think that having a way to tell clinicians at the bedside to try to achieve some standards is not necessarily a bad thing. I think it's a good thing. We can debate sometimes on the individual targets. However, if we look at hospitals, if we look at departments that have a good compliance with the bundles, what becomes apparent is that a place where we are more focused on doing some basic standards right, well, those places somehow are also characterized by a lower mortality. And I think it's a marker of an attention to care that basically does not focus just on one variable, but takes a lot of variables together and try to get things better for our patients. So I think the important thing to remember in septic shock, but for any shock state, we are working to improve the perfusion of the patients. And if we achieve that, that's great. If we don't, we need to think about using different strategies sometimes. Yes, we will see maybe more randomized controlled trials coming out and showing negative results. It does not mean that the physiology is wrong. It means that maybe our research question was wrong or that the population has changed. And I also would say that we now have monitoring techniques. And in those patients that do not improve quickly, I think they allow us to have a better physiological understanding of what's going on. And if we interpret the information properly, we can change our therapy and hopefully do good for our patients. Thank you.